So welcome everybody to the CHEPA seminar. It's my pleasure to welcome back to McMaster Jessica Shearer, who has recently completed her PhD in the Health Policy program here at McMaster. She's currently a visiting scholar at the Evans School of Public Affairs, University of Washington in Seattle. And she's going to be talking about measuring the exchange and use of research evidence in health policy making, exponential random graph models. So lots of quantitative stuff. So get out your calculators and be prepared for some good questions. So welcome back, Jessica.
Thank you, John. It's great to be here today, and I'm looking forward to sharing this talk with you today. So the objectives of the seminar are first to demonstrate whether, why, and how policy actors exchange or use research evidence in their decisions during policy processes, to demonstrate whether, why, and how evidence is used collectively by collective policy networks to inform the ultimate policy decision that is made, and then to outline a research agenda for this area moving forward. So I'll tell you now that the main finding of this body of work is that evidence exchange and use in policymaking depend on network structure. Okay? So I'm obviously going to unpack this to a great extent, but this is the main message. So we know that policies informed by research evidence can improve population health. Using evidence throughout the policy process can help us improve the efficiency and effectiveness of policy making, and also the output, so the policy decision or policy choice that's made will hopefully be more effective if we're using evidence to inform what the real problem is in our population, what are the most effective interventions to address it, how to best implement those interventions, and then monitoring the results of those policies. And there's also a global consensus that evidence should be used in policymaking. So the World Health Organization, a number of international funders and donors and national governments have said, yes, this is a valiant effort, a valiant goal, and this would improve population health, particularly in low and middle income countries. But we have a problem. We have two problems I would propose. So the first general problem is that in reality, evidence is not systematically used to inform decisions. And I think everyone in this room is probably familiar with that. And we know that there are a number of barriers that have been outlined in the literature. So for example, evidence is just not valued by policymakers in the policymaking process. It's not relevant or easy to use or timely when decision makers need it. And also there are many other factors in policymaking, such as interests, other types of ideas, institutions, and external events that compete with the use of research evidence in policymaking. But the other problem, I would argue, is that we do know something about what does work in increasing the use of evidence by policymakers, and that's actually the existence of interpersonal relationships between policymakers and researchers. So we know that that's something that works, and we've started to embed that into interventions for knowledge translation and for evidence-informed policy to some degree, but not entirely, and we don't really understand the mechanisms underlying that finding. So what is it about relationships that matter, and how can we tap into that? So I would argue that we actually have a no-do gap for our no-do gap. So in order to really understand interpersonal relationships and their influence on the exchange and use of research evidence, we need to take a lens or kind of a disciplinary paradigm that can truly study this. So social network analysis is a type of both theory and tool that can help us. It's a sociological theory. And it's very much in line with this hypothesis that has been forwarded by other authors, that the use of evidence by policymakers is a social phenomenon. Okay, so it's a social process that's happening. And if it's a social phenomenon, we need to use social methods. So as I said, social network analysis is both a theory and a toolkit. So from a theoretical perspective, if you believe in social network analysis, or if you see your world as a set of social networks, you believe that your individual level behaviors are not so much a function of your individual attributes as they are a function of your larger social structure and your social environment. And so as I said earlier, this is not currently being used, this way of thinking isn't being applied to knowledge translation. As a method or as a toolkit, at its very basic, network approaches allow us to actually empirically measure relationships between actors and policymaking. So this helps us to unpack that black box of policymaking. We know that relationships matter, but now we can empirically measure and map them and see what's happening there. And recent advances in the statistical element of this help us to be able to model those networks and the formation of those relationships. So this is a very linear and rational depiction of how evidence might flow through policymaking to eventually lead to evidence-informed health policy. So we assume that there's some existence of evidence. I would argue that then that evidence has to be exchanged, it has to be shared amongst people, then it will be used potentially by individual policymakers to inform their thinking on the topic and inform any decisions they might be making. But it will also be used collectively by the network. And I'm arguing also that these two things are different. But what I don't know is this simply the sum of this, right? So if you add up all the individual level uses, will that lead to a collective network use? And so no one's really studied this before, so this is going to be part of this. And then hopefully that will lead to evidence-informed policymaking. So these three central boxes represent three key research questions that I have in this presentation. So the first is to predict the probability that evidence is exchanged between two actors. And I'll be using exponential random graph models to do this. Second, to predict the probability that any individual actor in a policy network uses research evidence to inform their personal decision. And then finally, to predict the factors that determine the collective use of evidence by a policy network. So this study was carried out in Burkina Faso, which is a poor country, developing country in West Africa. It is one of the poorest countries in the world. There's obviously severe resource constraints and a great influence of donors in that setting. I studied 3 recent national health policy decisions, and so those 3 decisions, when I was there and I was studying these 3 cases, were the introduction of community health workers to treat childhood health conditions at the community level, the scaling up of a program that allowed community health workers to manage malaria at the community level, and finally the removal of user fees for antiretroviral drugs to treat HIV. I should mention that there is a relatively nascent culture of research use and production in Burkina Faso, but research was available for each of these 3 decisions that were being made, and it was used to some extent. My study is a mixed method study, so I employed both qualitative interviews and network collection methods. So in terms of the interviews, I interviewed approximately 80 policy actors. And so to define that term by policy actor, I mean anyone who is involved in policy making for these 3 issues that I studied. So that could be a Ministry of Health official, it could be an international organization staff person, a staff of NGOs, researchers, consultants, anyone who is assisting in some way with the development of these policies. And so I engaged them in in-depth interviews, and I asked them to describe the process. I asked them about other competing factors, institutions' interests and ideas, the role of research evidence, and through those interviews I was able to create these very deep and informative narratives of how these processes unfolded, as well as the specific role of the use of research evidence in these 3 cases. And also during those interviews, at the end of each interview, I implemented a social network survey. And this is basically just asking the respondent, okay, so during policy making for this issue, with whom did you interact with? Okay, and so they would give me a list of names. They would say, oh, I interacted with this person because we were on this committee together, and then, you know, we wrote the training guideline with this person. So they gave me a list of names, and I probed to make sure that I was getting the most complete list of names that I could. And then I said, okay, of those people that you just mentioned, can you tell me which of those you provided research evidence to? And so I'd get some subset of those names. And then, okay, and of all those people you interacted with, who did you request research evidence from? And again, I got a subset. And so through this method, you're able to construct networks for each of these relationships. So for interactions, networks of evidence provision, and networks of evidence requests. So after I'd received names from each respondent, I would then go out and interview all those respondents. And the goal of social network analysis is actually to do a census of the entire network. So there aren't currently reliable sampling methods for this, so it's very data collection intensive. You have to try and capture the entire network. And so, you know, I interviewed and I called people and I stood by offices, and eventually I'm fairly confident that I captured network data, captured all of the actors who were involved in these 3 policy cases. So ultimately, I end up with 3 different types of networks for each of the 3 policy cases, so a total of 9 networks. So let's see what those look like. So this is the network of interaction ties, or what we would call the interaction network. You'll notice first off that it's actually one network. You see the 3 issue domains there, but they're all connected because each of these policies were made at the National Ministry of Health level, and there's a great deal of overlap between actors. So each of the circles represents an actor who I interviewed and who I have data on. The size of their circle represents what is called their degree centrality. That's just a measure of how many ties they have coming in and out. So people with more relationships have bigger circles in this graph. The colors represent cases they belong to, although because, again, there are people who are involved in more than one case, there are more than 3 colors on the graph. But you can basically see that you have a child health cluster here, a malaria cluster down here, and an HIV component up here. So without even looking at quantitative data, we can make some more qualitative observations. So we can say, well, child health and malaria seem closer together, HIV is further apart. Substantively, that makes sense because child health and malaria were closer policy issues. In fact, I would have hoped to see even more coordination between the 2 policy domains. They were almost the same policy with the same policy goals, but because of the funding structures of international organizations, we end up having 2 fairly distinct policy domains there. HIV is a different issue, so it's further away. You'll also notice maybe that the child health and malaria cores look fairly round or circular. Particularly malaria looks like maybe it's relatively centralized or based around this big blue node, this blue actor here, whereas the HIV case has a funny shape. I think it looks like a kite, yeah?
Quick question, so the circles, are they just total number of interactions, or?
So they're sized according to total number of interactions in this case.
Are you able to capture intensity?
That's a good question. Yeah, so you can measure intensity of interaction. I did that in my survey, but I don't graph that here. So that would look like the lines would be different thicknesses, for example. Okay, yeah.
But getting to the shapes of the subnetworks, how were the nodes arranged relative to each other? Is it just a minimum spacing algorithm or something?
Yeah. So they're built-in algorithms to the programming, but it spaces it out according to how. So it's not spatially or geographically connected in any way, but it's a minimum spacing algorithm that represents these graphs.
So my question might be the same, but I don't know quite. So the distances between are based on what? So some are smaller and some are.
So it's the algorithm that creates those distances, but basically the algorithm is able to compute the network distances. So we know that these people are very close together because they all are reporting ties with each other, right? We know that, so that's how, and the computer has an algorithm. And unfortunately, I can't go into much detail.
Thank you.
So again, moving on to kind of shapes, the HIV shape is wonky. So as a network analyst looking at it, I would say, that looks very decentralized, not particularly dense. So the HIV network is very different, it seems, than these other 2 networks. So let's see if that has an influence on outcomes, okay? So that's the interaction networks. So now moving on, these are the ties of provision. So now we have directed ties. These arrows represent actor A providing research evidence to actor B. So you see that the nodes are in the same coordinate positions, but now instead of their interactions with each other, I'm graphing the provision of evidence from one to the other. This is obviously much less dense. Okay, so people are interacting, but they're not necessarily also providing. Okay, we start to see other things in terms of shape. I think the biggest feature here is in the child health network. We start to see a triangle in that network. So maybe it's one big triangle or a triangle within a triangle. This has implications. So we know from the governance literature that triangles and policy networks mean very congruent paradigms and very cohesive viewpoints. So triangles usually limit innovation, they limit new ideas. You're reinforcing the same paradigms because you have these kind of connected threes or sets of people who are very connected with each other. So those are provision ties. And last, we have the network of request ties. So this network is even less dense than provision. So fewer people are requesting evidence compared to providing it. Okay. Any questions before we move on about the graphs?
So just if I look at the child health network, the big red one, the arrow going at me, he's asking for evidence.
So the easiest way to think about it is he's sending a request.
Sending a request.
Sending a request tie or sending a provision tie. Yeah.
So the people, it looks like the people who are requesting are also from the one before providing. Is that right?
The people.
So the requesters are also the providers, or is that wrong?
Well, we will find out.
Okay.
But that's a good observation. Those are the types of things we can look at and wonder and then say, let's build those questions into our modeling. Yeah. All right, so now these are the descriptive statistics for some of the concepts that we just discussed visually. So across here I have the interaction network for the 3 cases and then provision requests. So let's just talk through the interaction. We know the number of nodes or actors for each network. The density is the proportion of ties that exist in this network out of the total proportion of ties that could exist. So a density of 1 means everyone is connected to everyone else, okay? So the densest network is the child health network. In terms of centralization, that's what proportion of all the ties are going to one or a few focal actors. The malaria network is the most centralized, and recall again that we saw that big blue node in the middle of their network. Organization, this is the number of organizations who are represented in each of these policy processes. So we have a lot of different organizations in malaria, fewer in child health, and then cross-boundary ties is the proportion of all the ties that cross organizational boundaries. So these latter 2 measures here to try and get at a sense of the network's diversity or heterogeneity. And again, the theory being that the more diverse a network is, the more exposed it will be to new ideas, right? And so I think that evidence is more likely to be exchanged and used in diverse networks. And I'm measuring that according to types of organizations who are involved in policymaking. And I won't go through the numbers for the other networks, but we'll get to that later. Okay, so now to introduce you to the actual modeling approach. So this is called the exponential random graph model, ERGMS. It's a form of a logistic regression, but as you may have seen already or may be thinking in terms of networks, network, either nodes or ties, are not independent units of analysis, right? So the whole premise of network analysis is that every tie or every node in a network is interdependent with the other nodes and ties around it and with the rest of the network. So we can't use traditional statistical models. We have to use something that controls for that dependence. And this is a recent innovation from 2006. People have started thinking, okay, we're now able to model the probability of a tie between actors I and J in a network Y, conditional on the rest of the network. So conditional on all the other ties and actors in this network. And we can model that as some function of both structural level and attribute level covariance. And I do this in R in the ERGM-StatNet suite of packages. And yeah, so it's been very helpful. There have been a lot of degeneracy problems with ERGM modeling, but again, the approach is kind of growing every day, and people are helping each other in the community to understand how to solve some of these degeneracy problems. I would also argue that if the models are degenerate, maybe it's not the right model fit, and maybe what you're looking at isn't a true social exchange process. So I'm hoping that the exchange of evidence is truly a social process predicted by network structure, and that we'll be able to see that in this model. So next I fit the models. Following Goudreau, Kitts, and Morris, which was an influential paper in this field, I fit 3 types of models. So I first started with what we would have done before, which was an attribute-only model. So this is the traditional way of thinking that an exchange of evidence between 2 people is some function of their attributes. So it's maybe because they have experience as researchers, or because of the job level they have, or the type of organization that they belong to. And homophily is just a term describing if they share that same characteristic. So for example, if they're both researchers, or if they're both in an MOH organization. And so that's what we used to do to predict something like the exchange of evidence. And so I'm arguing that we have to go beyond that now. So the next model I fit is a structural model, where now the covariates are all elements of the network structure, and I'll get to that on the next page. And then finally, I combine those into a full model that's thus controlling for both individual attributes and structural attributes. So here are the structural covariates. Now these are all social processes that sociologists observe more than chance alone in social systems. Okay? So in groups of people, we're likely to see transitivity. Okay? Transitivity is the closure of triangles, and what this means is that actors A and C are more likely to form a relationship if they have a shared friend in common, or a shared node in common. Okay, so that's the friend of friends theory. Okay, and again, we thought we maybe saw that in the child health network, right? And that in governance literature, that's linked to these kind of cohesive paradigms that are difficult to change. Reciprocity is also observed more than chance alone. If I lend you money, you're more likely to lend me money. Okay, so we're going to reciprocate the same type of relationship. And entrainment is like reciprocity for different types of relationships. So if I lend you money, you're more likely to, I don't know, babysit for my kid or whatever, right? So we have two different relationships in train, and that's more likely to happen than not in social systems. So I model for all of these. And so this is a descriptive table. So as in other types of regressions, we want to describe the dependent variable and its distribution. And so this is the distribution of out degree, meaning ties that are sent out in provision networks. And I have the child health in red, the malaria in blue, and the HIV in green. This looks like other distributions of networks where ties are relatively rare events. So we have a lot of 0 and 1 ties, or a lot of 0 and 1 degrees, so people aren't sending out any ties, okay? So this is just simply for describing, thinking about it, thinking how this might affect my models. The one thing that concerns me is that I have a few blips here. Will I be able to model that? Will I be able to model this steep decline here? We'll see, we'll find out. All right, so now on to the results. So remember, the first question that I'm asking is, how can I predict, or what predicts the exchange of research evidence, or the provision and the request of research evidence between two actors in a network? So these are the results of the ERGA model, which is what I use to do that. So this is just for the child health case, and I just want you to focus on the full model. Remember that I built these 3 models for each case, but just focus on the full one. You'll see that the first term that's statistically significant and positive is this WESP, or transitivity term. So indeed, people were more likely to provide evidence in the child health network, or a provision tie was more likely to form if it closed the triangle. Okay? So people are providing evidence in order to close triangles. The entrainment term is also significant. So a provision tie is more likely to form if there's already a request tie there between those people. Yeah?
So entrainment and these things, there's just, again, the number of times an individual has stated. How are you measuring entrainment? How are you measuring some of these other reciprocity?
So entrainment, for example, in the model, entrainment would be, so a tie would exist. A tie would be entrained if a request tie existed between those two nodes.
Okay.
Yeah. Yeah. So I'm measuring the existence of a tie between two given actors. So it's entrained, the provision tie is entrained if a request tie already exists between them.
Okay.
And so for reciprocity, remember, because one person I can provide to you and you can provide to me. So that would be a reciprocated provision relationship. We're both providing to each other. Okay? And we didn't see that. Okay? So people aren't sharing provision, they're providing and requesting. And nothing else is significant in the model for child health in the full model. So it's just those 2 structural covariates. So these are the other models now. So again, I'll just focus on the variables that are statistically significant. So we see entrainment is statistically significant across all the cases. So in this context, when there's a provision tie, there's going to be a request tie and vice versa. And so I think of this as polite behavior. So if I'm asking you for something, you will provide. Okay, so that is statistically significant in predicting ties across all of these cases. We start to see some individual level attributes that become important. So in the malaria case, if you had experience as a researcher, if you have some experience being a researcher, you're more likely to have a provision tie coming out of you. And if you're a civil society organization compared to government, you're less likely. In the HIV case, again, entrainment is positive and statistically significant. Being a development partner organization or being a staff of that organization compared to government makes you more likely to have a provision tie as well. Yeah?
Sorry, I'm a little bit confused about
okay.
how you measure the entrainment. So when you have your network, you know that two people share information.
Yeah.
But then how do you know that they share that information because of the third one? I mean, did you ask them?
Oh, for the transitivity?
Yeah, the transitivity.
Because we have this information, right?
Okay.
So essentially, so I'm asking, is this tie between these two people, is it any more likely if we have ties also going to their common friend, right? So indeed in the child health case, yes. Having a friend in common increases the probability or the log odds that a tie will be formed between actors A and C.
Okay, but it doesn't necessarily mean that that it just, I mean, like, just by chance they had a friend in common, but
So the theory is that it is because they had a friend in common. The theory is that people like to form triangles to cement friendships, and so in terms of friendship networks. In governance networks, it's to form alliances, right? To make sure that our common shared viewpoints remain the same, right? And it's also, I mean, it's also due to proximity. So we're more likely to know each other because we have a friend in common, because maybe we live in the same city or we work at the same office. But there's also this structural effect that seems to be more important than that. Yeah. Okay, so what I just described was predicting the existence of provision ties, right? So now predicting the existence of request ties. So again, we see a positive and statistically significant effect of the GWESP, or the transitivity term, the triangle term. So again, actors in that network are more likely to form request ties if it's completing a triangle, okay? Actors are also more likely to have request ties if they already have a provision tie between them. So entrainment's also significant again. And again, entrainment is positive and statistically significant in all of these cases. So again, it's this polite behavior if there's request, there will be provision. A few differences, again, in the Malaria network, having some experience or background as a researcher makes you more likely to have a request tie, and some different things are happening in the HIV network, where if you belong to the other category of organizations, so that's consultants or researchers, you're more likely to have a request tie. So that's basically it. So the main messages from this ERGM component are that the exchange of research evidence, either the provision or the request, seems to be more a function of network structure, so structural covariates, compared to individual attributes. So it's important to model those structural covariates, okay? And then we also have some specific examples according to entrainment and things like that, but I'll get into, and of course to the triangle term, but we'll talk about that in a moment. So the next thing, of course, after you do your regression models, you have to determine how well it fits. And now these are graphs of the observed out degree centrality, which we had looked at that other graph. And then you can kind of see faintly the modeled out degree centrality and the confidence intervals around there. So it's not perfect, but it's not terrible. And I didn't have model degeneracy, which I think is very telling in and of itself. So this suggests that this indeed is a social process that is modeled with structural covariates very well. As you saw from my end, my networks are pretty small. So typically ERGMs are applied to sexual networks or epidemiological networks with thousands, if not hundreds of thousands of nodes. So the fact that I was able to create convergent models with a relatively small number of nodes is pretty good. All right, so remember the next question was, okay, now we know something about the exchange of evidence, it's probably structural. So then what predicts the actor level use of evidence? And so again, I wanted to control for structural and attribute level covariates. In terms of structure, I basically just included terms in a logistic regression equation for their degree centrality, okay? And then also, of course, all these individual attributes related to their demographics and experiences in research and job level and things. The dependent variable of use at the actor level came from the in-depth interviews. So I asked people a series of questions around concepts of their awareness and use of evidence, and I then coded that onto a validated scale from Réjean Landry, who's based in Quebec. And so he's used this scale to measure Canadian policymakers' use of research evidence. I found that I couldn't ask this survey scale directly in this context of Burkina Faso, it just didn't translate well in that particular culture of research use. So I instead asked these very kind of detailed in-depth interview questions getting at that scale. So I ended up then coding that categorical variable into a binary yes or no in terms of research use. So what predicts an individual actor's use of research evidence? As it turns out, degree was the biggest predictor. And I modeled everything, but degree always just kind of threw everything out of the model. So degree seems to be the biggest predictor of an actor's use. The most important types of degree were, so this is red is child health case, for example. So actors in the child health case, for each additional unit of out degree provision in the network, so each time they provided evidence to someone, they were, their log odds increased by 4 times of using evidence to inform their own decision. Okay? We see the same thing for HIV. Malaria actually was so linearly autocorrelated that it dropped out of the model. So basically there's a direct linear relationship between providing evidence and using it to inform your own decision. In the HIV case, we saw there's a fairly strong effect of sending out a request for research evidence. So it's interesting that only in this case where people asked for evidence to inform their decision were they more likely to use evidence to inform their decision. Okay. All right, so that was a quick summary of that second question. So moving on to the third question, what predicts the collective level use of evidence in health policymaking? So now we're going to go back to those networks kind of as a whole. All right. So we know, and I don't know if I stated this explicitly in those descriptive tables, but we know that the Child Health Network had the greatest number of ties. So it was the densest network for provision and request, so it had the most exchanges happening. We also know that the median level of use by individual actors in that level is highest. So if we think that they're all connected, we'd say, well then, the Child Health Network as a collective would be using evidence to inform their decision. Okay? And actually, that was not the case. So the Child Health Network, we also know that there are lots of triangles in there, used evidence symbolically to inform their decision. So they used evidence to justify a predetermined decision that essentially had been made by donors, but the Ministry of Health were essentially supportive of that decision. There was a lot of exchange of evidence, especially by donors, to support that policy decision, but the evidence didn't instrumentally address the question that was being asked or the policy position that could have been taken. And in some cases, the evidence was even incorrect, okay? But it was mentioned a lot, and people were very proud that they were sharing these various studies that actually didn't have much to do with the policy issue. And so it's really neat that we see, yes, in all those triangles, there's this kind of congruent viewpoint. People are trying to kind of keep that viewpoint closed in. They're not reaching out. Remember, this network was also not very diverse, so they're not including outsider perspectives. Okay? Where we did see the instrumental use of evidence was in the HIV network, and remember how kind of decentralized that structure looked. Sure enough, it was the most decentralized. We saw, and it was also very diverse, and so in that network, people could access evidence and ideas. They could share it with each other, and people were more likely to take political risks in saying, here's evidence that can change the status quo. And in the end, the evidence produced locally to challenge the status quo resulted in changing the status quo, and the policy to make people pay for HIV drugs was repealed. So that's very exciting. And then in the malaria case, again, there was a high level of understanding and awareness of the research evidence in that domain, but it wasn't specifically instrumentally called upon to make the decision in the end. Okay. So what does this mean? So we have seen, so we kind of look at this in terms of what the networks look like. Now what about the numbers for these different values, density, centralization, heterogeneity here? So to make this easier to interpret, I've created what I call a scorecard, so red light, green light, yellow light. And so what I'm saying here, in terms of being an open network and a diverse or heterogeneous network, so the Child Health scored a lot of reds and yellow lights in terms of being open and diverse, okay? Whereas the HIV network, it was the least centralized, so being decentralized means you're open, right? And it also had a relatively fair amount of diversity or heterogeneity, yeah?
Go back to the previous slide.
Sure.
So HIV is decentralized, and this is good because there's lots of exchange going on. But it is HIV in Burkina Faso, which is African country. So how much of it do you think is HIV or the network, the decentralization of the network? If it was something else, do you think you'd have a similar conclusion? I don't know if that makes sense.
Yeah, that makes sense. I think definitely context and issue matters. I will say also about the HIV case, though, it is West Africa, so HIV is not as politically prominent as it would be in East or Southern Africa. And this case was the longest, okay? So we saw instrumental evidence in a policy, kind of contentious policy domain over 10 years, okay? So it's not to say that this was an easy decision. This was an easy decision, where evidence was used symbolically, right? So this was a fast process, this was a fast process. This was a long and contentious process that maybe almost required the instrumental use of evidence to finally kind of change minds about the status quo. Yeah. All right, so this is again the scorecard. So basically what we do see is that decentralization and maybe diversity, openness seem to be associated with network level, so collective level use of evidence. But again, we just have 3 cases. This is kind of nice to move forward with as a research agenda. We don't know how valid these types of results are. But I would also say that this is consistent with the governance literature that talks about innovation, policy innovation, the introduction of new ideas, and kind of these closed and open paradigms. All right, so the conclusion from this then is to know your network. I would argue that if we're interested in evidence-informed policymaking and knowledge transfer, we need to adopt not only a network lens and also network tools. So those 2 things are different but come hand in hand. Some of the major findings from exchange, actors are either provider or requesters, but not both. Okay, so we see that entrainment, people are providing or requesting, but evidence exchange is hierarchical in the sense that people weren't providing to each other, so we don't have the horizontal, we both provide to each other, which is really a true exchange, right? So we don't see true exchange, we see a very hierarchical, I'm higher up, I will provide and you'll request from me, or something like that. We also saw that requesting happened much less frequently than providing, suggesting that maybe the social or political capital necessary to invest in requesting is much higher, particularly in that context, than providing. I think we could deal with this by creating a more supportive culture and climate for the exchange of evidence. So in interviews, people would say things like, oh, I can't provide, I'm only this or that. I'm not a researcher, so I can't provide. And then other people would say, well, I don't request evidence because that's a lot of trouble for the person I'm requesting from. So it's just not a normal day-to-day activity that people engage in, and so there seem to be some kind of costs associated with it. So again, the transitivity, which we tend to observe in social networks, we only observed in the child health network. And again, I ask, is this potentially an empirical marker of symbolic use at the network level? And then finally, this is kind of a long statement, but essentially the whole is not the sum of its parts necessarily, right? So the individual level use of evidence at the actor level did not translate to collective level use. And it's only with mixed methods and kind of in-depth qualitative methods that I was able to untangle those 2 different processes. Otherwise, I probably would have left saying, oh, look, child health wins. They had the most provisions and requests. They had the most individual level use of evidence. Yay for them. They used evidence to inform their policy. So it wasn't without that in-depth qualitative aspect that I could say, actually, it's not quite the case. All right, so now I'd like to move on very briefly to how we can use this information moving forward, both methodologically and to design interventions. So in terms of ongoing methodological plans, one of the major limitations of my study is that it was cross-sectional. It is not showing how these networks evolve dynamically over time, which of course is happening throughout policymaking. So I'm currently involved in a project to measure policy networks longitudinally in Uganda around immunization decision-making, and that's funded by the Gavi Alliance. In addition to that, I'm interested, once I have those data, to modeling the co-evolutions of networks, policy preferences, evidence use, evidence preferences. So how do these all change over time as they interact with each other? I'm interested in replicating these methods not just for policy networks, but also for implementation networks. So one idea would be, well, we have this great data for policy making in Burkina Faso. For each of those cases, could we now trace the network of implementation all the way down to the ground? So I think that would be really interesting. And as I mentioned, I don't know if I mentioned this, but missing data is a huge problem in social network analysis and in modeling these networks. And also data collection. I did mention that data collection is very difficult in this context. You want to try and capture everyone. So how can we start to either capture that more rapidly and easily, or sampling methods, or inferring missing ties and nodes? And so I'm interested in working on some what are called ego network-based approaches. So based on one person's network, you can start to sample out the rest of the network, or Bayesian techniques to infer structure and missing ties. And then finally, I think we need to work on validating our measures of evidence use. So I'm fairly confident in my interpretations of evidence use because my methods were so long and drawn out, and because I do these really detailed qualitative interviews and I'm able to triangulate. But if you're doing a study like this more quickly, do we have a scale? How do we measure evidence use both at the actor and at the network level? So one of my intervention ideas is called Network RX. It would be an easy-to-use software tool. So for example, an HIV civil society advocate in Burkina Faso could use this tool to map the policy network around HIV. And so it would be based on inbuilt algorithms from my data that would kind of help him model his network. And when I say model, I mean really simply draw it out, listing names and kind of putting people in the place. And then it would diagnose issues in the network. So it would say, your network is very centralized. If you want to increase the likelihood that evidence or ideas or information will be exchanged and used, maybe you should start some committees here and here and here, and that will decentralize your network. So I think that this could be potentially interesting and something that requires a proof of concept study, of course. The Gates Foundation, for example, is interested in this type of tool. It could also be used for the McMaster Health Forum in terms of mapping networks to identify people that come to stakeholder dialogues. So currently the forum identifies people on a kind of a sampling approach. Yeah, you can correct me, but yeah. And I'm arguing that it's one thing to look and see who we think are the most important stakeholders, but if we could actually map the network of policymakers, we could target the most important stakeholders because sometimes they're hidden. And here's a great example of that. So while I was in Burkina Faso, there was a stakeholder dialogue for the malaria policy case, okay? And so the stakeholder dialogue was about using evidence to inform the malaria decision that was happening at that time. They invited a range of people. So this is the malaria policy network. I've coded in red the nodes who were invited to the dialogue or who attended that dialogue. You can see that there are a lot of red nodes in this network, but it's certainly not all of them. So if they had had this picture when they were inviting people, they could have said, oh, well, these are the people that we need to invite, and specifically these central people or these people who are in strategic brokerage roles. And so that's it. Thank you very much. I'd like to thank, of course, the Ministry of Health in Burkina Faso, my thesis committee, especially John Davis, and my colleagues at the University of Washington and the net modeling group there. Thank you.
Questions, comments?
That last picture with the dark green or brown, so you only figure that out, well, I'm assuming when you went there. These are hidden actors, so they're hidden. How would you, I'm a bit confused.
Well, I found them out from mapping the network, right? So I mapped, so this is I just took that out of those other big pictures we were looking at. This is the malaria case policy network, right? Which I mapped through my study. But then, and I just did this the other day, I said, okay, of these people who were actually involved in policy making for malaria, how many of them attended the dialogue that had been sponsored about policy making for malaria and about the use of evidence to inform that policy? And it turns out, I don't know the frequency here, but maybe a third of them had attended that dialogue. But I would contend that that dialogue would be much more effective if all of them or a greater proportion of them had been invited. So the idea is that before you invite people to the dialogue, you would map the network of policymakers and then see who is important.
It's really cool, especially the central ones, right? Which
Yeah,
are all
yeah,
brown, which weren't there.
yeah.
So Jessica, I think at the beginning you said you have a presentation for an interview.
Yeah.
So who are the whole faculty, or who are the type of people that are being?
So the main group of people are affiliated with something called the Center for Health Decision Science, and they do a lot of decision science, a lot of economic evaluations, cost effectiveness work. So I think they're mostly either modelers, kind of disease modelers, epi-modelers, or health economists.
Okay, so I'm just going to give you just a bit of feedback for you to consider and doing it.
Thank you.
Because I'm very interested. This was very great. I love this. So just at the beginning, you used this term "no do," and you used it quickly, and it was too quick.
Okay.
You either have to explain it or not use it.
Okay.
I thought it was good. Just a few things about your the table with your results where you highlighted in yellow, you need to change that because it looked like everything was highlighted.
Okay, yeah.
From here, I've got
Nice.
good eyesight, I couldn't quite figure that out.
And I'm assuming,
That's just a
I don't need to
presentation.
include, you know how I've included all three models in those like that? I don't need to include all of them?
I don't know, it's interesting, it's just, I don't know whether that, there's a 3 boxes
Can't,
highlighted or,
Yeah.
anyways, that's a
Yeah,
little thing.
yeah.
Now, the one part, at the end of part 2, when you talked about conclusions,
Mm-hmm.
some of your conclusions were surprises to me, even though I had followed all the results. And I think those aren't conclusions, but they're more discussion of your results. So
Okay.
when you talked about evidence exchange is hierarchical, that was new to me.
Mhm.
Social, political, requesting, provided. Just actors, reader, providers, requesters. I thought when I saw them they were both. I'm not sure. So maybe this is, again, not a conclusion, but more of a discussion of results. I don't know if John may think something different, but it just, for a conclusion, it seemed surprising as opposed to you coming up to say,
Yeah, no, you're right. I hadn't used some of those terms. I hadn't used the term hierarchical
right.
in my
Yes.
my explanation of
Yes,
results.
well, it's interesting.
Yeah.
I loved hearing it, but just it needs to maybe be explained more earlier on than that. Let me just. Oh, and I think more time on the scorecard, because usually scorecards are go, be cautious, and stop. Right? But this is. Oh,
So maybe scorecard's the wrong word.
yeah, usually when I think of red, green, and yellow, it's. They
Okay.
use that in a lot of health, right,
Yeah.
you know, so, so I don't know, but this is more good, bad, and ugly, or something.
Yeah.
So, maybe just a different term, or the colors of the terms or something wasn't quite right, and a bit more time on that, because I was trying to read, and I didn't quite get what you were saying with this.
Okay.
Questions or comments? From others?
Generalizability, about your research findings, what do you think are lessons learned for different contexts, or however you want to interpret that, I don't know.
I guess I could think of that in terms of both internal and external validity. So in terms of internal validity, I think that these results are very strong for the cases that I studied, but as you saw, there was a lot of heterogeneity across the cases, right? So in this way, and that's why one of my conclusion slides was called Know Your Network, we can't now just say, oh, this, we know this was what happens, exactly what happens in networks, and it will be the same for every health policy network that we ever see, because we saw 3 different networks. So I think there are some aspects of those networks that potentially we can start to generalize in a very broad way. So I think the idea of triangles being an empirical marker of maybe symbolic use or kind of closed paradigms might be true. Decentralization consistently across all literature, so organizational sciences, governance, politics, decentralization is always an indication of innovation, of being exposed to new ideas. So I think those types of things we can probably generalize. But yeah, in terms of across contexts, it was nice that I saw that many of the some of the results like decentralization were the same as in developed countries. So this work has never been done in developing countries. So that made me confident. So if they can translate across developed and developing, then hopefully, certainly they can translate within Africa, for example. But the role of donors, I didn't get into that too much here. One of my arguments is I think that donors end up subsidizing or somehow artificially changing the structure of these networks by their intensive role in providing research evidence. So those findings probably aren't the same as what we see even with interest group politics in high-income countries. So I need to do more work there to figure out, what to make of that.
So the donors are people who are donating money and research. So, okay, I wasn't quite clear on that too.
Well, they're donating money because they have a policy preference.
Gotcha.
Okay, so the Global Fund for AIDS, TB, and Malaria wants, X malaria intervention to be introduced, and they also provide all the evidence that supports that intervention. That might not be the best intervention for the country.
I thought that was great. I thought you walked us through it really well. One thing that wasn't as clear to me about the networks themselves in the beginning, and maybe it's because I don't know the policies themselves, right? Because you said, well, it makes sense that child health and malaria together and HIV is over here, but to me, I would want to see, I would think, that HIV would be more closely networked and linked with child health as well, child maternal health, HIV, but maybe that's the nature of the policy.
And the nature of the organizational structure.
Okay.
So in many African countries, HIV offices are now directly under the president of the country. So they've been elevated with such political priority that they're not even in the Ministry of Health. So there's usually the National AIDS Commission or whatever in that country. And so they sit physically in a different place. They have much more political clout usually. Whereas child health and malaria sat on the same campus within the Ministry of Health. They tend to have more overlap in terms of people who are actually involved in those two issues, but of course it depends on the country. But
Right.
Yeah.
Just at face value, it didn't make sense to me why it was that. And then I would just second that I thought the conclusion was really important, but maybe making that 2 slides, because those points were more like discussion, policy recommendations, a really good point, but a bit separate.
Okay. Thanks.
Well, congratulations. It was a really wonderful presentation. It was very clear, and I really liked how you applied this quantitative data to, at the end, having an application of this study. There was only one thing that I was a little bit lost, and it's actually this slide. Maybe I was lost or I missed something. Because you didn't tell us how you define the symbolic use of evidence and the instrumental use of evidence. And I mean, when you talked about it, I thought, did we define that previously? How did you define that? Maybe your audience doesn't really know what these 2 things are, so just a small recommendation.
Yeah.
To
That's one of my challenges to fitting the whole dissertation into a short amount of time. But yeah, so to answer your question, and you all might be familiar with Weiss's categories of these types of research use. And so basically, again, from coding my qualitative interviews and triangulating with documents that have been used in the policy and the policies themselves, coding each decision onto one of these categories, or one of Diane Weiss's categories. That was a really, really tricky endeavor because, the big message is that research evidence is used in many ways at the collective level, even during policy making. So in the end, I had to say, okay, which was kind of the most critical way, the way in which, had it not occurred, the policy wouldn't have moved forward. So really, in the HIV case, if it wasn't for that evidence, that policy wouldn't have changed. Whereas in the child health case, the funders were always going to give the money to introduce the policy.
So these are findings from your qualitative.
Yeah.
Final question or comment?
Just your ease at answering the questions, it's obviously a really good grasp, because just your answers are so much interesting, and it's coming across. And when you said that a lot of people in the audience will be modeling people, I don't have enough background, but the way you talked about what happened to that was very easy, and you could tell good work. Yeah.
Super, excellent. Thank you very much for joining us.
Thank you so much, everyone.